Thank you so much for having me here. It's been just exciting to hear Dr. Ken Wong talk. I've known him for a while, and definitely hear Maureen's story. Maureen has been such a pivotal part of Morse Cancer Center. She was being treated right when I was starting at UCSD, so I actually remember this journey very, very well. And I remember you were literally our first patient that we used surface-guided radiotherapy for in a locally advanced breast cancer case. So as I was hearing your story, I was thinking, we talk about these technical terms: surface-guided radiotherapy, motion management, image-guided radiotherapy. These words mean a lot to us. But what does it matter for the patient every day, right? The patient that comes into your clinic every day. And I thought of, really the 3 C's. Maureen talked about the first C, confidence. Your patients need to feel confident in your ability to take care of them. Compassion. That's the biggest thing that we can give our patients, our passion and our compassion, so that we take good care of them. But ultimately, when you're treating these patients and they're in your vaults on a daily basis, what matters really for most patients, it's not the technical things that you do, it's the comfort. It's the comfort in that cold room where they spend 15 to 20 minutes every day for whether it's on the order of a day or order of a week or 9 weeks. It's really the comfort. And how do we maximize comfort for patients? And I will say that surface-guided radiotherapy has really been a key driver in ensuring patient comfort. And that's what I'm going to talk to you about a little bit today. So I was thinking about this. I've been at UCSD now about 8 years, and ever since I've been there, we've had surface-guided radiotherapy. So to me, it's something that's ubiquitous. It's part of our daily experience. We are a very busy department. You can see we have 4 sites in San Diego. That doesn't count the Proton Center, which is our 5th site. We have 8 linear accelerators. And we have surface-guided radiotherapy on 5 of our machines today, with the 6th one hopefully coming later this year. So this is something that we use virtually in care of, I would say about 30 to 40% of our patients, routine daily external beam radiotherapy patients get some form of surface-guided radiotherapy, whether it's for a CNS radiosurgery case, whether it's for a deep inspiration breath hold in breast cancer, whether it's doing tattooless treatments in our left-sided breast in our breast cancer patients, or gating, or now even in our stereotactic body radiotherapy patients. I'm going to talk to you a bit about our radiosurgery world and deep inspiration breath hold in lymphomas, which is what I do a lot of. So as you can imagine, in radiosurgery, compared to 15, 20 years ago, when I started practicing radiation, we used to put frames on people, right? How many of you use frames today, where you bolt somebody's head? Yeah, so minority, right? So I would say about 5% of you still use frames. So going back circa 2004, when I started my residency, I would say that number was probably 80%, right? 80 to 95% of patients had a bolted frame that a neurosurgeon would come down, bolt the frame in before you did your treatments for any kind of high-dose radiosurgery in the brain. And the frame mattered. Not only did it provide good immobilization, it really was your motion management system. Back then, there was no image guidance on the machines, and so there was certainly not intrafraction motion management system on any of our platforms. So when we started with Vision RT in literally 2009, really our goal was to see how do we make patient care comfortable in the radiosurgery world. And the first thing we all agreed on was getting rid of that damn frame. It's a pain for the patient. Literally, you have to. It's a procedure with risks of infection, bleeding, all those things. It's not comfortable, and the treatment takes a long time. So our first venture in surface-guided radiotherapy in 2009 was to come up with a frameless and what we called maskless. It was not quite maskless, but the mask became open. And so we've been doing radiosurgery with an open mask since 2009, so literally 10 years out, and with no frames. And there are a bunch of publications you can look up, both on the clinical end and technical end. And back then, when we first started in 2009, our aim was really, hey, can we use surface guidance and do this safely and accurately? And so that's where we started. Now, over time, we've gone from doing surface-guided radiotherapy in brain tumors with using a single isocenter for a single lesion to now doing multiple lesions with a single isocenter. So, and this is our radiosurgery volume. So you can see in 2009, on a daily basis, we would treat on the order of one patient, every other day. Today, in 2019, we are a very busy radiosurgery center. We do all our radiosurgery on one of our true beams in our mothership, and we treat on the order of 12 to 15 radiosurgery cases a day, and I would say 60% of those are brain cases. So we do a lot of radiosurgery, a lot of high-volume radiosurgery. How many of you do, if you were to think of your brain metastases patient, how many of your patients get whole brain? 10%, 20%, 30%, 5%? Does anybody know? Do you guys, how much whole brain you do versus radiosurgery? 5 to 10, yeah, right? So again, 15 years ago, we used to do radiosurgery in patients literally with 1 to 3 brain metastases. So it accounted for maybe 10 to 15% of patients with brain metastases. The tide has completely changed, right? Now, 95% of patients with brain metastases get radiosurgery at most major centers in the US, whether it's academic or private practice. I mean, I can count literally, we treat over 6,000 patients a year. We do on the order of about, over 900,000 radiosurgery cases a year on those patients. And I can count that we probably do 15 to 20 whole brain patients a year. I think that's a fair number to say. We actually track the number of whole brains we do a month, and it's on the order of 1 to 2. So majority of these patients, whether they have 1 brain met or 20 brain mets or 30 brain mets, are getting radiosurgery. And there is a good reason for that, right? We have a treatment that is extremely effective in providing local control. And patients with brain metastases are living for a very long time. My longest patient right now is 10 years out since the diagnosis of brain metastases, living well, got married, had kids after being diagnosed with brain metastases. So the paradigm of how we manage stage 4 cancer today is very, very different. So what else do we do with surface-guided radiotherapy? I will say, majority of our intracranial volume is still brain metastases, whether it's, definitive brain metastases or postoperative after they get a resection. About 20% of our patients have benign tumors, so meningiomas, pituitary adenomas, vestibular schwannomas. And then I would say about 5% of our patients have these very rare sites, the tumors, right? So AVMs. And then I do trigeminal neuralgias, which Matt's right there, which we'll say we probably do about half a dozen cases a year. It is extremely anxiety provoking, and we do not use a frame. So we give 90 gray to a 4 millimeter through a 4 millimeter cone using surface guided radiotherapy. As you know, there are multiple platforms. I think surface guided radiotherapy has really changed the way we use linear accelerators in radiosurgery. Again, 15, 20 years ago, 80% of patients were treated on, maybe like 50% of patients were treated on a gamma knife. Today, over 98% of radiosurgery happens on a linear accelerator. You can do this treatment absolutely anywhere and everywhere. And I think surface guidance has really a big part of this because you can manage patients and track their emotions so well during the course of these treatments. So in terms of radiosurgery, we all know this. We give these very high focus doses of radiation. We ensure that the radiation dose drop-off is very rapid. We have these exquisite planning systems. But the key things that then come into play is accurate delivery of the dose and accurate positions. And this is where, gone are the days of putting frames or big masks. We use these open masks that you can see on a daily basis. And image guidance really allows us to treat this exquisitely accurately in a very quick manner. What's the average duration? Dr. Wong was talking about this, right? We used to do radiosurgery. We used to take a single brain met, and the delivery 5-7 years ago would take on the order of 30 to 45 minutes. Today, we book these appointments in 15-minute time slots, right? We treat a single isocenter, literally within 15 minutes. If we were doing multiple isocenters, we give them a 20-minute time slot, and we never reach our 20 minutes. So in terms of using surface guidance, as you all know, as Dr. Wong talked a bit about this, I'm not going to go into all the details. We basically use Align RT every day to set up the patient. We start with a KV match to make sure that there are no major rotations. Then we do a cone beam CT, and then make our final shifts based on the cone beam CT. And then we use that cone beam, the final shifts to capture the align RT as our zero offset position. In our department, we generally give it on the order of 1 millimeter margin for our brain metastases, and the really 0 millimeter margin for most of our benign cases when we do radiosurgery. And our threshold is 0.1 millimeter, typically in 0.1 degrees, where we start. When you do, most of us do couch kicks now when we do radiosurgery. So when you're doing couch kicks, you do need to correct your couch rotations to acquire these parameters. But this is something that, with surface-guided radiotherapy, you can do very, very well. Wanted to show you what an average patient for us looks like. So typically we do on the order of 3 to 4 arcs for a simple radiosurgery case. And you can see the motion where we have here. It's on the order of 1 millimeter, which is our tolerance generally on these patients. So I would say in brain, really, surface-guided radiotherapy allows for an extremely comfortable treatment. You can treat literally from pediatrics. As Dr. Wong talked, we actually do a fair number of pediatric cases when they present with radiosurgery, both for palliation and for brain metastases. And you can treat the extremely older patients, as Maureen talks about. I will say my record is not quite 104, but 102. So we are literally seeing these patients that are octogenarians, nonagenarians, who really need that comfort on the couch. And as Maureen points out, the hard table. I can't really do much about the table, but I can do a lot about the head and face when I treat them with radiosurgery. And then you need to be able to monitor these patients. I realize that our treatments are getting much, much quicker, where you're treating these patients now. Literally, the beam on time for our average radiosurgery case is on the order of 5 to 6 minutes. Literally, 5 to 6 minutes is the beam on time. But even in this short beam on time, surface guidance really allows to make sure that you're treating these patients very accurately. And I can't emphasize the frameless, it really has revolutionized the way we do radiosurgery. How many of you have hyperarc, or the Electa equivalent of hyperarc? Are you guys doing that? A few of you. So as hyperarc allows for, it's a fixed geometry system, which basically uses one coplanar field and 3 non-coplanar fields. And this actually allows for even a faster delivery of patients because the fields are preset. You can use 6 FFF in terms of your energy. And the gradients are even better compared to standard. So, typically in radiosurgery, we aim for a gradient of 0.5. With hyperarc, we're seeing gradients of 0.3 to 0.4. So that means that the radiation dose fall off is exquisitely rapid. The other thing hyperarc really allows for is that it really builds in a collision prevention system. So you don't have to do a QA to make sure that the fields are going to clear. And with this technology and surface guidance, our treatment times, we're literally booking patients into 15-minute time slots, and oftentimes double booking because my therapists are so great that they get through these cases very quickly. Just wanted to show you an example of one of our hyperarc patients. So you can see this is a patient with 20+ lesions being treated, with a single isocenter, and this treatment is done, the beam on time is on the order of 7 minutes. So extremely quick. The second half of this talk, I really wanted to talk about lymphoma because I think this is where surface guidance is still a novel concept. So as you all know, in lymphomas, historically we used to treat these patients with very large fields, what we called, involve field radiotherapy. And you can see this field on the left right there, where somebody with a tumor in the chest literally got radiation all the way from the neck, all the way going down to below the carina. So these large fields of radiation. And today, we've really moved away from that. We use what I call quasi-radiosurgical margins in treating most cancers, right? We put a margin on the order of 3 to 5 millimeters, and that's true in lymphoma today. With modern radiotherapy, we typically use margins of 3 to 5 millimeters on gross disease, or in the post-chemo cases, after we contour the post-chemo tumor bed, again, margins of 3 to 5 centimeters generally in most directions. And the technology has evolved too. Historically, we used to treat most lymphomas with very simple beam arrangements, a beam from the front, a beam from the back. We're doing APPA. And more, this is now all being treated with intensity modulated radiotherapy, volumetric arc-based radiotherapy. And because we have a proton center in San Diego, in the appropriate cases, especially my pediatric Hodgkin's cases, with protons. So how does image-guided radiotherapy play a role in this era for lymphoma where our fields are much smaller? I think the key thing in lymphoma, especially Hodgkin's lymphoma, what I treat a lot of, these are patients from 15 to 35 years of age. It is a disease that is exquisitely curable, cure rates of 85 to 95%. So majority of your patients are going to live on the order of 20 to 60 to 70 years out post-radiation. And the biggest thing that we know, particularly from the pediatric data, is that radiation causes long-term side effects. Especially in the days of APPA radiation, the risk of second cancers, was as high as 30 to 35% in Hodgkin's patients over their lifetime. The risk of heart complications, and this is the world that I obsess about, is really, sparing the heart as much as possible. If you look at long-term Hodgkin's survivors that were treated from 70s to literally 90s, the risk of long-term cardiac complications in these patients are up to 40%. They actually exceed the risk of secondary breast cancer in these patients. Because, when the heart sees an average dose of 20 to 30 gray, it is a gift that keeps on giving. These patients develop valvular disease that requires valve replacement surgeries 20 to 40 years out. They develop atherosclerosis, so they get heart attacks 20 to 40 years out. They can get restrictive pericarditis, which is very, very difficult to manage in these patients. So one of the things that I worry about a lot is how do we spare the heart today? Just like in breast cancer where we use deep inspiration breath hold, and as you all know, 15, 20 years ago, we used to do fluoro to set up our breast patients. We wanted 2 centimeters of lung to set those tangents, right? I don't know how many of the therapists here are old enough to remember that. Do you guys remember that, right? We used to want 2 centimeters of lung on fluoro. So we treated a crap load of lung, pardon my French, and the heart on a left-sided breast cancer was always in the field. So the LAD, especially the inferior aspect of LAD, literally saw 50 gray of radiation that you gave to the whole breast. This is some interesting data that came out in 2016. Actually, in 2014, it came out for breast cancer, where we showed that for every gray of radiation seen by the heart, the risk of heart disease goes up by about 7.5% per gray of radiation over the lifetime of that patient. Similar to that, there was a similar study done in patients with Hodgkin's lymphoma to look at the impact of radiation dose on cardiac toxicity. And it showed exactly the same thing, that if you looked at long-term Hodgkin's survivors, the risk of cardiac complications is dose-dependent. So you can see here on the graph on the right, so the blue is patients getting pretty high doses of radiation. These are patients being treated APPA for Hodgkin's lymphoma. And you can see that the risk of cardiac complications is about 30% at 40 years out. As the radiation doses to the heart go down, you're really able to spare cardiac toxicity. So today in 2019, when I treat lymphoma, the goal is to keep cardiac toxicity over the course of their lifetime to a rate of about 5% or less. What that means is you have to get that heart mean dose to 5 gray or less in these patients. And the only way to accomplish that is with a combination of deep inspiration breath hold and surface guided radiotherapy. That is the standard today. So as patients take these deep breaths and hold it in, what we do in left-sided breast cancer patients, the same technique applies for lymphoma patients. It does 2 things in lymphoma patients. It not only moves the heart down and out of your radiation field for vast majority of patients, it also expands the lungs. So now your tidal volume, as Dr. Wong showed earlier, can go up on the order of 1 liter. So your ability to spare your lungs also improves drastically in these patients. Here's just showing you what DIBH looks like in an average lymphoma patient. So you can see as you take that deep breath in and hold it in, your lungs expand. And if you're treating during this position, you're able to spare more of their normal lung. And really what's more impressive is the heart. So unlike in breast cancer patients where DIBH helps you spare their LAD, in lymphoma patients, the LAD generally is not in the radiation field, even with big APPA field treatments. It's really the valves. So it's the aortic valve and the pulmonary valve, which are the highest sitting valves of your heart. Those typically fall in the radiation field and typically see full dose of radiation. So if you're giving 45 gray to a mediastinal lymphoma, it sees that full dose of radiation. And then the vessels that actually see radiation in lymphoma patients are the right circumflex and the left circumflex. So the vessels, they start right by your valves and they go down towards the apex of your heart. And the goal is really to spare those vessels and to spare those valves. And so you can see here, you get the first 2 or 3 centimeters of the heart in a standard free breathing field. And when you do a DIBH plan, you can eliminate virtually all of the heart from the radiation field as long as the pericardium is not involved. In lymphoma patients where the pericardium is involved, those are the only patients where I really think protons play a role, because no amount of deep inspiration breath hold or surface guidance is going to help you spare the heart without protons. So here's what DIBH looks like. So you can see here, we do exquisitely IMRT-based planning today for lymphoma patients. And you can see this is the image on the left is basically a patient where they're free breathing, and you can see that the upper 1/3 of the heart is right in the radiation field. And when you do DIBH, that heart comes completely outside the radiation field. These are some of the orders of magnitude of difference that you see. So, in majority of inverse planning lymphoma patients, if you look at a free breathing plan, the mean heart dose is going to be on the order of about 10 to 15 gray, versus if you had done an APPA plan, the mean heart dose was on the order of 15 to 25 gray. When you do DIBH and a VMAT plan for these cases, the goal for mean heart dose should be 5 gray or less. It should be exactly what you do in a left-sided breast cancer patient. The other thing that DIBH allows you is to really also decrease that lung dose. So the mean lung doses go down from the order of 15 to 18 gray down. You really want to keep the mean lung dose down to 10 to 12 gray in these patients. And you can see that the DIBH really allows that. That's the biggest thing that allows you to do that. And all these DIBH strategies require some kind of motion management. And in our practice, we use Vision RT. That's our standard for these patients. Again, showing you the decrease. So you can see these are looking at, this is data published in the Red Journal, and our data looks exactly the same, where you compare a APPA plan free breathing to an IMRT plan free breathing to a DIBH plan free breathing, and then an IMRT DIBH plan. And you can see that both the mean heart dose and the mean lung dose go down with these techniques. So how do we set up DIBH for these lymphoma patients? We typically use an S-board. We typically use a head and neck mask, except we roll up the head and neck mask on the chest so that you can capture their chest using Vision RT. The biggest thing is really making sure that just like your left-sided breast cancer patients, that they can do an adequate breath hold. We treat with what I call a modified butterfly technique, where we use these partial arcs. They're typically 3 arcs from the front and 2 arcs from the back, to spare the breast tissue and to spare the lungs as much as possible. And we do these arcs, we tailor these arcs to the duration of the time that a patient can hold the breath. Which, in a young person, surprisingly, they can hold breath for 40 to 50 seconds very, very well. In older patients, we try to limit these arcs to about 20 minutes. We do 2 scans. We do a deep inspiration breath hold scan with contrast, and then we also acquire a free breathing scan just for comparison. And this is what the mask looks like. So you can see the mask. This is one of my recent patients with refractory Hodgkin's lymphoma, where we cut out the mask right in the chest so that we can use Align RT to capture their chest anatomy. In terms of planning, as I mentioned, typically partial arcs are very helpful in these patients. And for the dosimetrists in the room, really, working hard to both spare heart, lung, and in a young woman, breast tissue as well. So today, the average heart dose for a DIBH lymphoma patient really is on the order of 2 to 3 gray, exactly like a left-sided breast cancer patient. And the mean lung dose, you can see, we try to keep it below 13 gray. Historically, when you did APPA for a lymphoma patient, the V20 was easily 40%. I don't know if you guys have I don't know how many of you do APPA for lymphomas in the chest? Nobody, right? 5 years ago, most insurance companies would have laughed at you if you said you wanted to do a VMAT plan. I'm really happy to see that now almost every insurance company approves that. So today, right, the V20 for lung, you really want to try to keep it below 20% if at all possible. We export the initial surface contrast both from the free breathing and DIBH CT to Align RT. And we actually usually set up using the free breathing CT marks on the patient. Then we have the patient take a deep breath in on the day of on their verification simulation day, and then we switch to a line RT. And we start with a KV-KV match. We do these partial cone beam CT, so we do basically 3 20-second cone beam CTs where we do a third of the arc each of the time to get a whole cone beam CT. And then our tolerance are 5 millimeters. So typically I put a 5 millimeter PTV margin, and that's my tolerance for daily setup in these patients. And this works really, really well. I would say that we treat over 99% of our lymphoma mediastinal patients with DIBH. It's very, very rare where a patient can't do DIBH. Those patients are typically patients with really, really bad COPD, or patients who have had 5 to 6 lines of chemotherapy. They've had so much chemotherapy that they have a lot of lung toxicity where their lungs just don't move very well with the breaths that they take. I'll end by saying I think surface-guided radiotherapy is really integral, I think, in most radiation oncology practices today, whether you're treating breast cancer patients, whether you're doing radiosurgery in the brain, or whether you're treating lymphoma patients. I think it really allows for us to deliver radiation safely, it is efficiently, and as I mentioned, most importantly, comfortably, which is something that I really want to make sure that's a key part of the patient experience. Vision RT allows you to kind of have a motion management solution that's very easy to implement, and it's extremely reproducible. Thank you.